President Trump's One Big Beautiful Bill Act is soon to become the law of the land. In its final version, it was 887 pages long. There are some Americans that are excited about it and actually love it, and there's others that absolutely hate it, and there's plenty of people in between. One side of the political aisle says that this law is going to destroy America's healthcare system. The other side said it's the only way that it can be rescued. So regardless of a person's political persuasion or the type of insurance that you may have, whether that's Medicare, Medicaid, a marketplace plan, or even a group plan, rest assured that every single one of us are going to be affected by this law. So in this video, what I'm going to do is look at the details and the consequences of this law and show you the impact that this law will have on you and America's healthcare system. Now in this video, I'm going to reference several different articles that I think will really help us to understand the impact of this legislation. I'm going to begin just with a summary of what one particular author wrote, because I think this sums up well what we'll be discussing. He says this: the bill includes significant changes in enrollments, eligibility, and premium tax credit rules, as well as cost-sharing reduction payments. Combined with the expiration of the enhanced premium tax credits, the bill would result in an individual market that looks fundamentally different when the full effects of all the changes occur. And I think that's really the essence of what we're going to see. This is truly going to change everything in the American healthcare system. All right, to set the stage here, what I want to do is I want to go back and actually look at the history of Medicare and Medicaid and currently what's changed ever since this began in 1965. Of course, President Lyndon Johnson was the president at the time, and he and Congress worked on putting together a healthcare system for those people that retired. There was not much of an individual market. Certainly people no longer working or covered by group plans. So they began this system, and it was for people 65 and above, and of course they had to be U.S. citizens to qualify, and of course paid into that particular system. Now, there were some changes beginning in 1970 to about 2000. They began to add others to the roles of Medicare, and the first one would have been those that had end-stage renal disease. This is permanent kidney failure. Someone that's either on dialysis or waiting a kidney transplant would qualify then at any age for Medicare. And then someone with Lou Gehrig's disease, same thing, at any age. And then what happened, they began to give people that were receiving Social Security disability benefits automatic enrollment into Medicare A and B on their 25th month of having received disability payments. And so this is why there are many people today that are not yet 65 but are on Medicare A and B because they came through the disability system. Now, when it comes to funding, I want to talk about how this works. So funding, of course, is different depending upon A or B, the original Medicare, but Part A funding is done by us. We pay into Part A. We're taxed for Medicare. And the money that we pay, it would be FICA taxes or self-employment taxes. Right now, we pay 1.45%. The employer matches that. If you're self-employed, you pay the full 2.90%. And so all of our income is subject to Medicare taxes. So it's funded. And the Part A actually would be the hospital trust fund. Now, just so you know, if you're a single person above $200,000 in income, you pay an additional 0.9% of that income that's going to be above $200,000. A married person filing a joint return, if they're above $250,000, they pay an additional 0.9%. But my point is this: we are funding Medicare Part A through our payroll taxes. Okay, now Part B is funded differently. Part B is actually funded by premium payments that we have to make, which are really based upon our income. Right now, in 2025, people are paying $185 a month if they're above certain income thresholds. Single people above 106, married people above 212,000. In modified adjusted gross income, they pay an additional amount for their Part B called an IRMA. That's a surcharge. So we pay premiums into the Part B system, but also general revenue from the federal government provides funding for Part B as well. Okay, so that's how Medicare is working today. Now let's talk about Medicaid. So Medicaid, again, began at the same time, 1965, but it was for a very special group of people, and that would be those that are considered to be pretty low income. In fact, frankly, very low income, or those that were actually disabled. Remember, disability kind of came in later for the Medicare, but here it was for people that had disabilities. All right. right, now, what happened then, again, during the next 30 years, there would be some changes, and they would begin to add categories of people who qualified for Medicaid. And that would be anyone that was a pregnant woman, of course, children or parents that had low income. All right, and so this was kind of how it worked for many years until the expansion of Medicaid, which we'll talk about. But the funding is different. So Medicaid is actually a federally funded plan as well as state, but the state has really the flexibility to be able to establish their own rules. Okay, so federal and state funding, but states oversee the program. And so what happens is this: the government historically has paid about 50 to 78% of the cost of Medicaid coverage in each particular state. So if we have a state that has good revenue, high income, they're going to be kind of on the lower side. If we have a state where traditionally there's more lower income people, maybe a state that does not have as much of a budget, then they're going to get a little bit more funding from the federal government. So again, that's how much the federal government paid for many years. And of course, this would begin to change, and we'll talk about how the Medicaid program began to expand. All right, now let's quickly look at the history of the Affordable Care Act / Marketplace plans. This became law, ACA did, back in 2010, actually March of 2010. President Obama was our president, and the ACA became law. Now, when it was first passed, what was going to happen were states would be required to expand their Medicaid program. Required. It was going to be mandatory under the ACA law. But what happened was the Supreme Court had a case, and they examined the case and decided that states did not have to expand Medicaid. It could not be made mandatory. It actually had to be optional. And so that was the ruling here. So what happened was 40 of the states plus the District of Columbia decided they would cooperate with the expansion of Medicaid and the ACA plans, and then 10 states did not. So they're non-participating with expansion. So we have 40 that did, 10 that did not, and of course DC did as well. All right, so what happened, they of course took a couple years to get the ACA instigated and everything going. And so we have our very first open enrollment for ACA plans October of 2013. And then those new plans actually began January 1 of 2014. All right, so that's kind of the history of how ACA was developed. I just want to pause just real briefly because I know a lot of you that are watching this are Medicare eligible. And if you'd like to make sure you're staying up to date on everything related to Medicare as well as Social Security, if you've never subscribed to our channel, we'd love to have you subscribe. There certainly is no cost to do that. It's totally free. And if you'd like to give us a thumbs up or even a comment about any of the videos that we do, we would greatly appreciate that. But those who do subscribe are notified every time we do new content. Okay, so we have new ACA law. We have 40 states and DC that decide that they're going to participate in the expansion of Medicaid. So let me show you exactly what that looked like and really the impact for this. We have what we refer to as a new national eligibility group. In other words, a group that's added to that original list. Before, it had to be low income, it had to be women that are pregnant or children, low income families, and that was the only group. But now we're going to add a large group, and this is going to be a new group, and this would be anyone that is an adult that is age 19 to 64, and their modified adjusted gross income is below 138% of the federal poverty level. The federal poverty level established, of course, on an annual basis. And prior to this expansion, someone had to be at or below the 100% of that federal poverty level to qualify for Medicaid. Now, some states, it wasn't 100, it actually would be lower than that, but it could be no more than 100 to qualify for Medicaid. Now we have this expansion, and so they raise the income level and then add adults. So these are people that do not have to have children. Could be a woman, could be a man, but again, they're childless adults. And so we have this new group that's going to now be eligible for Medicaid. All right, that brings us into this federal funding. In other words, how are they going to be able to expand and encourage states to expand their Medicaid program? Certainly there has to be some funding behind that. And so what we have is an acronym here called the FMAP, and that stands for the Federal medical assistance percentage. Let me say it again, federal medical assistance percentage, FMAP. We'll talk about that with some of the changes with this new law as well. So here's the way it worked. So what happened in the first 3 years of ACA, 2014 to 2016, the government said that they would provide 100% funding for all these people that are going to be covered now as a result of expanding Medicare. So they're going to cover this group differently, 100% of the funds. And then what happened from 27 to 19, they began to lower that percentage. So in 2017, they covered 95% of it. In 2018, they covered 94% of it. And then 2019, they covered 93% of the expansion group. So again, they're covering the majority of the cost. And then what happened in 2020, they lowered that then to 90%, and this then has been permanent. But as you're going to see with the passing of the One Big Beautiful Bill Act, that is actually going to change. But this is how it was through 2021 up until the passing of this new legislation. All right, so another thing that happened is they expanded ACA expanded Medicaid, and now we have these Affordable Care Act plans, is they have streamlined enrollment, trying to really expedite the enrollment process. And so someone's eligibility, now notice this, the eligibility is now based upon their modified adjusted gross income. And we know for Medicaid purposes, it's all the way up to 138%. But for ACA purposes, it's actually going to be up to 400% of someone's modified adjusted gross income. All right. And so we'll look at the actual formula for this in just a minute. But again, we have to be financially eligible. And then what you're going to see with the passing of the One Big Beautiful Bill Act, that's actually going to be reduced. And you'll see here in just a second. All right. In addition to streamlining eligibility, now we also can do everything online applications, and all this will be then coordinated then and combined with the ACA marketplace. We call that the Federal Exchange. You can call healthcare.gov and actually make arrangements to get one of these plans. All right, so this is the kind of the components of the new Medicaid rules and the ACA plans. Okay, so as you saw on the previous slide, eligibility is based upon someone's modified adjusted gross income. Now, frankly, in the financial world, there are different formulas for modified adjusted gross income. There's a different one for Medicare than what we're going to look at here. But the point is, let me show you the formula real quickly so you'll see exactly how this works for eligibility purpose. So first off, we start with adjusted gross income. If someone's looking at the 1040, that's actually going to be line 11 on the 1040. Secondly, what we're going to add is tax-exempt interest. Now, frankly, most people don't have this, but if you do, that means you invest in municipal bonds or sometimes savings bond, U.S. savings bonds, that you don't have to pay federal taxes on that interest, those earnings. You have to report them, but you don't pay taxes. So that is actually on line 2A of a 1040 form. All right, so we're going to add those two together. Then what we're going to do is we're going to add non-taxable Social Security benefits. I think most people know that all of our Social Security benefits are not subject to income taxes. In fact, some people, none of their Social Security income is subject to taxes. Some people, 50% will be, and some 85% will be. But the point is, when we look at a tax return, we have two lines under Social Security. It says line 6A is what we're getting total in Social Security, and then line 6B is what is subject to taxes. So now what they're saying is because the portion that's subject to taxes is already in your adjusted gross income, so the difference of that now has to be added back in, meaning all of our Social Security is going to be a part of this equation. So we're going to add that in as well. That which was already taxed and that which was not taxed needs to be included. All right. So again, that line I'm talking about here would be line 6A. Line 6B was the one that is actually a part of the adjusted gross income. All right, then in addition to that, we have two other items here, and most people are not going to have this, but I want to make sure you know it's part of the ACA Medicaid formula, and this should be foreign income. These are people that work clearly outside the country, and their income up to a certain limit, I think this year it's like $124,000, is actually exempt, but it has to be added back in for ACA purposes. And then because they have foreign housing, they rent, utilities, and different things, they also can deduct that off their taxes, so that's excluded. But it cannot be for the purpose of ACA modified adjusted gross income. So the whole point is this is going to be the formula we're going to use to decide exactly what kind of a subsidy someone would be eligible for. All right, that brings us then to the federal poverty level chart. And by the way, this is 2025. These numbers change on an annual basis, just based upon inflation. And so what we're going to do is I'm going to explain a couple terms to you that matter certainly this year, but also matter with the changes with the One Big Beautiful Bill Act law. Okay, the first one is called a premium tax credit. Premium tax credit. Okay, and so what this means is that when our premium on our insurance plan, regardless of the carrier that you have, the majority of people are getting some type of reduction of premium. And that money is not going to be paid to them directly. What happens is it's actually paid to the insurance company to reduce the premium that they have to pay for their insurance. So it's a premium tax credit. And so now people that have consistent incomes, meaning salary or hourly type work, they can pretty much project what their income is going to be for the coming year, and that premium tax credit is very easy to assess. So let's say someone's on a plan that costs $1,000 a month, and you get a premium tax credit of $800. That's going to be applied immediately, actually forwarded to the insurance company on a monthly basis. So they may have to pay out of their own pocket $200 a month, or maybe even less than that. But the point is, this is actually applied to the premium, and it's done on a monthly basis. Now, people that have fluctuating income, what happens is they get their premium tax credit differently. Some get it advanced because they know what their income is going to be. Others with fluctuating income do not. They actually then would get that tax credit when they file their income taxes. Either way, the net result is still the same. It just depends on if you're getting it advanced, you get a reduced premium. If you're not, then you may pay full premium, but you'll see that back then when you file your taxes. All right, so this is a big deal. One way in which people are having a reduction in their insurance premiums on a monthly basis. All right, so that's that. Now the next one is CSR, and what this stands for is this is a cost savings reduction, or cost sharing reduction, really. Cost sharing reduction. All right, so what this means is this is somebody that not only got a premium tax credit, but also some of their out-of-pocket expenses are reduced. So this could be reduced deductible, reduced co-payments, reduced co-insurance, reduced max out-of-pocket. So all the components that we have to pay out-of-pocket for our healthcare expenses then can be reduced based upon, of course, what we qualify for based upon the federal poverty level. So those are the two ways in which people benefit or are incentivized by the ACA marketplace plans. And then there's another thing I'm going to teach you about, and this is called enhanced premium tax credits. Okay, enhanced. All right, so the same thing up here, but these are enhanced. So let me explain exactly how this works. What happened in 2021? We had the American Rescue Plan Act, ARPA, American Rescue Plan Act, and then we had the Inflation Reduction Act, and this would have been in 2022. And so what happened was, for these particular years, what they did is they changed the formula and actually allowed more people to qualify for premium tax credits. Okay, and I'll show you how this is going to work here in just a second. But again, with the passing of the One Big Beautiful Bill Act, this is actually going to change because these particular tax credits actually are going to expire 12 of 2025 at the end of this year. And they're going to expire, and there's some that wanted to renew them, but in this act, they're not going to renew those. Okay, now let's look at the chart and let's begin to talk about how the equations of these numbers here actually affect premium tax credits and cost savings reductions. And so what happens is this. Anyone that is at the 138% federal poverty level or below, okay, these people now are going to be qualified for Medicaid. So when a state expanded its Medicaid program, it agreed to begin to cover under Medicaid insurance anyone that's going to be here or below. Okay, that 138%. Now, in the old days, before ACA expansion, then it would have been 100% or below. So again, we have this new group. So what happens for premium tax credits and cost sharing, these people do not get those because they're on Medicaid. So premium tax credits and cost sharing actually begin here. We move forward. And so the way this is going to work with a premium tax credit, originally it would have been this group right here. Anyone that would have made anywhere between 150% to 400% of the federal poverty level was going to be qualified or eligible to get some type of a reduced premium for their Affordable Care Act plan. Of course, you can see household size. And by the way, when we talked about modified adjusted gross income, it was anyone that was working in the home as well as those that were dependents that you claimed as a dependent. Their income as well had to be included into that modified adjusted gross income. So that's what we're talking about. It would be household income, household size. All right, and so what happened then, this group here under ACA got some sort of a subsidy. And again, it's kind of on a sliding scale. And so obviously these people got a greater benefit than what these people did. But again, they got something, all right? And so what happened in the original days is this. You would pay no more of a premium than 9.8% out of your pocket of your modified adjusted gross income would go towards your insurance premium. That would be the max, so they kind of max it out. But anyone that was above $400% of federal poverty level, they got no premium tax credit, and where there was no subsidy, there was nothing for them at all. So the cap would have been right here, and again, the formula would have been at this level, they had to pay 9.8%. But after that, again, no cap. So those that are high income receive no benefit whatsoever. And this was a system that was in place for many years until 21 and 22. Now I want to clarify something here real quickly when it comes to cost sharing reduction, because not everyone is going to get a cost sharing reduction. It's actually this group of people here. Anyone between 100% of the federal poverty level up to 250%. This group here would be eligible for a cost sharing reduction, meaning they don't have to pay full out-of-pocket, deductible, co-pays, co-insurance, max out-of-pocket. They got help. All right, but up to 250%. So these people here were not qualified for that. Still qualified for a premium tax credit, but not the cost sharing reductions. Another thing about these is a person had to be enrolled into what is called a silver plan. Remember, we have bronze and gold and platinum plans. None of those qualified for cost sharing reductions, only the silver plan. So people had to enroll into those particular plans. Okay, so that's the way that's going to work. So this is exactly how the system worked from 2014 up until the passing of the American Protection Act and the Inflation Reduction Act. So the whole point is this is how it worked. And then what they do now is they're going to enhance premium tax credits. They're not going to enhance cost sharing reduction, but now more and more people are going to be qualified to get a reduced premium through the premium tax credit. So they set the new rules. And now what happens is no one would spend any more than 8.5% of their income on their premium. That was the max cap. So even high income people, if they have a premium above 8.5%, they too are going to get a premium tax credit. Again, it's going to be applied to the monthly premium, or it's going to be settled up at tax time. And so what happened then is before these acts, no one paid more. No one got a subsidy if they made above 400%. Now there is no limit. In other words, you could be very, very wealthy and still get some kind of a tax credit because, again, the max would be 8.5%. And again, these things are set to expire at the end of the year, and with the passing of OBBBA, that is exactly what's going to happen. They're not going to renew that particular aspect of the premium tax credits. Okay, now that we understand that aspect of the federal poverty levels and the premium tax credits and cost sharing reduction, let's talk about some other changes that are happening now with the passing of the One Big Beautiful Bill Act. Okay, the first one is the way Medicaid and the amount of Medicaid funding that they're going to actually get from the federal government. Okay, and so here's what we saw earlier. We saw this acronym, which was the FMAP, and that stands for the Federal Medical Assistance Percentage. That's the matching by the federal government for the state's Medicaid program. And so what's going to happen, you're going to see this, now it's going to be reduced. And so we remember earlier we talked about whenever the whole program started back in 2014 all the way to 2016, federal government paid 100% of the cost of that Medicaid expansion population. And then remember, it went down, it went from 95, 94, 93, and then in 2020 on, what happened? They paid 90%, and this is exactly where we stand today. But with the passing of this bill, what's going to happen, this 90% is actually going to go to 80% matching. and that's it. So it's reduced. Now we look at it and say, well, that's only 10% less, but that's huge for the majority of states. Let me just show you a quick example. Let's just say that some state has 500,000 people that are part of their expansion population. Now, childless adults up to 138% of the federal poverty level, now on their Medicaid program. We have 500,000 of them. Average cost, let's say it's $8,000. That's a pretty reasonable number. That's what it's going to cost the state. And so that equals to be $4 billion. $4 billion. So of that $4 billion presently, what's happening? The federal government is paying 90% of that. And so that means the state's paying 10% of that, which is actually going to cost the state $400 million. Okay? And the federal government paid the rest, the other 90%. But with a reduction to 80% on the federal matching, what's going to happen now, that those same people, the cost is the same, but now because they're getting less money, it's actually going to cost them $800 million to cover that expansion population. And again, that's going to put some strain probably on some states' budgets. So the whole point is now with this new bill, there's going to be less money coming from the federal government into the state budgets for their Medicaid population. All right, so the second aspect that is happening because of the OBBBA bill as it relates to Medicaid funding is this statement here: phasing down the maximum provider tax rate. And now again, most folks wouldn't even be aware of this, but with those states that actually agreed to expand Medicare, the federal government allowed them to have a tax on providers. And these providers are typically going to be managed care insurance companies. They're going to be nursing homes, hospitals. Rarely are doctors taxed or ambulance service, but many people in healthcare business are going to be taxed, and this is allowable. But what happens? The feds set a maximum. So right now we have a 6% max tax on these providers. Now keep in mind, where is this tax going? It's going actually into the state budget. So they tax the provider. That money then goes into the state Medicaid budget, and then the government again has been matching that up to 90%. Again, that's going to go down to 80%. And so what they're doing, they're just saying we're not going to allow you to tax them as much because we're not willing to match as much. And so what's going to happen the very first year now that with the OBBBA bill is that this is going to go down to 5.5%, and then it's going to 5%, and then it's going to 4.5, and then 4, and then eventually it's going to stop at 3.5%. So as you can see, they're going to kind of gradually remove the ability for them to tax so much. And so again, the federal government eventually is not going to have to be matching as much because the state's not going to be able to charge as much taxes to those particular providers. So again, what's that going to? The net effect is going to be less in that Medicaid budget, less money matched then by the federal government. All right, then that brings us to the third consequence of this bill, and that is financial penalties for non-compliant states. Right now, there are states that actually cover non-citizens, even documented citizens, and so they actually fund that health insurance out of the state Medicaid budget. Not all do, but many do. And so part of the changes are going to be the eligibility for people being able to get different plans based upon their citizenship status. And so for states that decide they're going to go ahead and cover people that the federal government says are no longer eligible, if they catch them doing that, then what's going to happen is they're going to give them a financial penalty. That would be a non-compliant state. Now, I think eventually states can have a workaround in that they can set up their own insurance pools if they want to do that. But they're going to use the normal Medicaid program. What's going to happen is every quarter they actually, the government sends them a quarterly matching amount. And so if they find that they were non-compliant, they will not get their quarterly matching amount. And again, we're talking about billions of dollars here. And so again, they're trying to put some teeth in this to make sure that these states are complying with the new Medicaid rules. Okay, so that'll be a big deal as well. So we'll have to see exactly how that fleshes out. We believe that some states are going to set up their own way to cover these people instead of just going through the traditional Medicaid program. All right, so those are the Medicaid funding changes. Now let's look at the Medicaid eligibility changes, because these two are going to be huge. The first one will be now they're going to establish work requirements for those that are on Medicaid. Now, not for everyone. There's people that will be exempt, but some are actually going to now have a requirement placed upon them it's actually called this. It's called a community engagement rule. And one writer said this way, said the bill proposes new community engagement rules requiring able-bodied adults without dependents to complete 80 hours per month of work, training, or volunteer service to maintain their Medicaid coverage. And so originally that's what it was going to be. Anyone that had dependents were still raising children would be exempt. They changed that in the final version, and now it's this. Here's the new wording on it. Parents or caregivers of children age 15 or older, so 14 or below, you're exempt. But if you have children 15 or above, you're no longer exempt. They too must complete the 80 hours of work. It could be volunteering, education, or other qualifying engagement. Okay, so this means they're working, they're getting paid. It could be that they're going through some kind of job training or job education for the 80 hours. It could be voluntary work as well, or just proving that they're searching for a job or other approved programs. But the point is they want people that can work or that can volunteer to be doing that. So again, 14, if you have children 14 and below, exempt, but at 15 and above, or you're single, then you're going to have to fulfill this particular work requirement. So that is also a huge change. All right, that brings us into the second aspect of eligibility, and that's this statement here. There's going to be an elimination of coverage for certain groups of people, meaning no longer going to be eligible for premium tax credits, cost sharing reductions, the different incentives that come along with ACA plans, but also Medicaid eligibility as well. All right, and so I like this particular statement, kind of a summary again. This bill directly eliminates coverage for some subgroups. And then he says here, for example, under Section 71110, Medicaid eligibility for non-citizens would be severely limited to a few specific groups, ending eligibility for refugees and other lawfully residing non-citizens. So again, they're here in the country legally, but they are not citizens. This would be a couple examples. Anyone who is what is referred to as an asylee. This is someone that was granted U.S. protection after fleeing persecution. So under this new legislation, they're no longer going to be eligible for either premium tax credits or for the cost sharing reduction. Anyone who's in a refugee status, they were admitted directly from abroad due to persecution. Again, they're disqualified from subsidies. Those are TPS holders. This was just in the news about some from Haiti, temporary protection status. They're non-citizens. They've been allowed in the U.S. temporarily due to unsafe return conditions. So under this law, their subsidies also have been removed. Okay, so they cannot get them. Anyone that's called a special juvenile immigrant. These are children under U.S. juvenile court jurisdiction unable to reunify with their parents. Under this new law, the subsidy eligibility has also been revoked for them. And so the whole point is we're seeing this happen. We're certain that these groups are just no longer going to get help in the way that they did in the past. All right, then that brings us then to the third aspect here, and that's increased frequency of redetermination. And one author said it this way. He said the act calls for more frequent checks on Medicaid eligibility, potentially leading to more people losing coverage due to paperwork or procedural issues. And so what they're doing is, up to this point in time, people did not have to, on a regular basis, prove that eligibility, that status that allowed them to get the tax credits or, qualify for Medicaid. And now they're going to have to do that. And so with this higher degree of accountability and the frequency of redetermining this eligibility, that, of course, could affect people staying on their insurance plan as well. All right, so those are the things that are changing because of this law. All right, that brings us now then to the changes that the law is going to have upon the ACA plans and the marketplace plans. And so here's the way we're going to see changes now with the law. Shortened open enrollment period. This is going to change now from November 1 through December the 15th. Okay, so we're going to have about 6 weeks. Prior to that, we had at least 8 weeks, and some states would even expand that beyond this. And so again, people are going to have to get real serious about doing their re-enrollments because less time to do that. Number two, it's going to eliminate automatic re-enrollment. The majority of people are passively enrolled into these plans. If they had a plan, they were automatically enrolled. That can no longer happen. They're going to have to go back through and re-verify their address and their income and go through these different hoops hoops to make sure they're going to still requalify. Okay, so again, it's not passive any longer as it has been in the past. All right, so shorter time, not passive. And then they're going to end this, what's called the provisional premium eligibility. What this meant is if somebody applies and they're going through that paperwork process, sometimes the paperwork takes a while to go through. So as it stands today in 2025, before the passing of the law, what would happen is these people would then have about a 90-day window to clear up any discrepancies, to complete the paperwork, and to do whatever they needed to do for that policy to actually be issued. But while they're doing this waiting, they're still covered. They're still getting their premium tax credit, their cost sharing reduction if they're on that silver plan. And so what's going to happen now is they no longer will be. In other words, they're going to have to make sure all the paperwork is done correctly, it's done on time, because if it's not, then they're not going to get any of those premium subsidies, no incentives whatsoever. So that's going to go away, these provisional. So they're going to have to be real serious about making sure everything is buttoned up very quickly and that they're eligible, because again, that could cost them dearly financially. And then that brings us to this, and then that is the tax credits that we talked about earlier expiring. Remember the American Rescue Plan Act 2021, the Inflation Reduction Act of 2022, it allowed more people to qualify for premium tax credits. Remember, prior to this, if you were above 400% of the federal poverty level, you had to pay full premium. We had a max at that 400% of 9.8%. And then what they did with these acts, they said now more people qualify, and the max that someone would spend would be 8.5%, and there was no income cap at all. That meant almost all people are going to get some kind of help. And so the point is, those are not going to be renewed. The act said no, these are actually going to expire. So that's going to impact people's premiums. In fact, they say that some people could see an increase anywhere from 25 to 50% because they're going to lose that premium tax credit. And then lastly, just like we saw with Medicaid, we're going to see reduced eligibility for certain groups. So people that could have qualified for AC in the past no longer are going to. Again, it's going to be really a lot to do with their citizenship status or how long they've actually been in the country. Those people that have been here less than 5 years, it'd be very difficult for them to get any kind of coverage. Those after 5 years, then their citizenship status is also going to come into the equation. But the whole point is this: because the passing of this law, certain people that may have had coverage in the past probably not going to be able to get it in the future. All right, that brings us now to how this law is impacting Medicare. And before I get into that, I just want to mention something to you, those of you that may be approaching Medicare eligibility and starting to make some decisions. We have what we call an Essentials Workshop that I do a new one every year. It lasts about 50 minutes, but it gives all the ins and outs of Medicare. It truly would give you all the information that you need to know to be able to be confident in your Medicare choices. You can go to our website, MedicareSchool.com, and there's a link there that you can actually click on, and it will take you to that Essentials Workshop. There's no obligation, there's no cost for it whatsoever, but it would really help you to understand Medicare very, very well. And again, it gives you everything that you need to know. And the whole point is we want to make sure when people go on Medicare, they can do so without making any kind of mistake. All right, so let's now look at how OBBBA is affecting Medicare. All right, so Medicare eligibility, of course, is not changing for anyone that is a U.S. citizen, or even a naturalized citizen. They have paid into the Medicare tax system for at least 40 quarters, or their spouse did, or their ex-spouse did, and they're approaching 65. That is certainly not going to change at all. But what I'm going to do is just make a contrast between how it is today as I shoot this video in July of 2025, and then what's going to be after this law is then fully implemented. Okay, so today, here's what happens. A person does not have to be a citizen to be able to get Medicare. As long as they are a legal permanent resident, meaning they hold a green card, and they've been here for at least 5 consecutive years, they're actually eligible for Medicare. And of course, that's going to change. They just have to be lawfully present, 5 years, and they actually qualify for Medicare Part A. Now, if I'm going to get Part A at premium free, I'd have to be here for, working for at least 10 years, or my spouse or ex-spouse. So we can actually draw that presently at 0 premium for Part A. Now, if someone does not have the 40 quarters, they're still eligible to buy Medicare Part A. A lot of people pay for Part A, so you can buy into that presently. And then also you can qualify for Part B. Part B, that outpatient side of Medicare, that we pay a premium for. Most people $185 a month this year. And so they also get extra help if indeed they're low income and qualify for one of those Medicare plans. And so this is how it is today as I am sharing this video with you in July of 2025. But the bill is passed. And so what's going to happen now? Things are going to change for Medicare, not just Medicaid and marketplace plans, but for Medicare. Now, in order to be on Medicare, you have to be a U.S. citizen. What's that mean? Well, there's people over here today that are on Medicare that are probably going to lose their Medicare eligibility because now they have to be a citizen. And so they have to be lawfully present for sure, but look what happens. They can no longer buy Part A if that's their only status, meaning they're even a green card holder. Again, they can't buy it any longer. There's no more extra help eligibility for them as well. The only way they're going to be able to do it then is if they go through the naturalization process. In other words, becoming a citizen in that particular way. Okay, that's the only way. So again, a big change for several 100,000 people that are on Medicare now that may lose that because of this bill. All right, so that's all about the Medicare eligibility. Let's talk about some additional changes as well as a result of this law. And the first one is we have an expanded definition of a rural emergency hospital. And frankly, folks, the reason for this is because with some of the impact that's happening on Medicaid now, the reduction of eligibility, the reduction of funding, people are very concerned about the stability of rural hospitals. And this has been a problem for a while, but we believe this is probably even going to increase. And so what they're doing is they're going to allow more hospitals to be defined as rural emergency hospitals. Now, what this means, obviously, they're in rural areas. These are certainly not in cities. Large hospitals could not function and could not, financially survive in a rural setting. But these kind of hospitals may be able to. And so what happened was they've defined a rural emergency hospital as hospitals certainly in a rural area or an area that would be maybe close to a suburb. They're just redefining this. Let me just read this to you. Rural emergency hospitals are a type of Medicare designated facility that operates in areas where bigger hospitals may struggle to stay open. And what happens is these hospitals receive a monthly payment just for remaining open. And they also get a 5% increase on outpatient payments to help ensure they're able to continue providing care for residents in those rural areas. And right now, there's only, I think, 30 some of these hospitals throughout the country. But by bringing about this particular act and this law passing, what they're going to do is they're hoping that some of these hospitals that have closed will reopen now. Because to have this designation, they had a cutoff date years ago. It had to be designated as a rural emergency hospital by 2020. And so a lot of hospitals did not take that status. They closed down. So now what they're going to do, they're actually going to backdate that eligibility and say if you're a hospital that operated from 2014 and 2020 and you closed because you couldn't make it financially, we're going to allow you to come back and apply for that program. And so what they're hoping is there could be anywhere from 300 to 500 of these hospitals or maybe more that will reopen again and begin to serve those communities by this particular law. So this definition is in moving from rural to semi-rural and also those serving underserved urban fringe areas as well. So again, they're redefining this so more will be able to participate in the program. And so again, I think these hospitals get like a $5 million a year payment just for staying open. And then a normal Medicare reimbursement rate is going to be increased by 5%. And again, these are hospitals that are providing outpatient care, emergency care. They have beds, so there could be someone that's maybe under observation, but it's not really an inpatient status. It's totally outpatient, totally emergency care to take care of people in the rural areas. One other neat thing that they're going to do, and this came out with the bill, and this was part of the Senate version as they negotiated between them and the House, and they're actually going to give $50 billion. It's $10 billion a year for funding these rural hospitals to make sure that they're able to make it and stay in business. Okay, so that's really a good thing as well. And then number two, some AI tools to recoup improper Medicare payments. I think most of you know there's a problem with the wrong coding. There's a lot of fraud, waste, and abuse within Medicare. And so this bill is going to give $25 million to the Department of Health and Human Services under Robert Kennedy, and they're going to hire developers and hire some tech to be able to start finding more and more of fraud, waste, and abuse. Right now, it's in the billions of dollars. I think original Medicare about $30 billion in overpayments. Medicare Advantage plans somewhere around $15-16 billion last year, and so this is a huge problem today, even among Part D plans as well. So there's a lot of abuse that happens, a lot of waste in Medicare. So they're going to make this AI investment to be able to recoup some of that money that's wasted by the federal government. And then lastly, what I want to talk about is what's really been in the headlines a lot as it relates to Medicare, and that is some have said this bill is going to cost Medicare to be cut by $500 billion. And I'm not saying that's not going to happen, but the likelihood of that is very minimal. So let's talk about why we're hearing this $500 billion numbers. Well, it all has to do with what's called sequestration. This has to do whenever Congress puts forth legislation that is going to increase the federal spending, the deficit, then there has to be certain cuts to programs. That's called sequestration. So let me kind of explain this just with this article I thought was very good. And this author said this: sequestration is an automatic spending cut. It's kind of a budget haircut, some people call it like an emergency brake, that the government applies when it spends too much money. Okay? It was created to force fiscal discipline. Another example of this, this author said this: think of sequestration as like a credit card rule. If you overspend, add to the deficit, which this bill is doing, your bank, Congress in this instance, is supposed to automatically freeze or reduce some of your spending the next month. Sequestration. Okay? And so the way it works is this. Medicare has a small protected card, meaning they're not going to freeze the whole Medicare card, but they will lower the spending limit by 4%. All right, and so that's sequestration. So that's what they're talking about here. Again, this is adding to the deficit. They're going to have to make some type of cuts. Okay, so let's talk about this. Medicare is protected from deep cuts for sure, but not entirely exempt because, again, this particular bill was an increase to the deficit. And so the way it works, the maximum that Medicare cuts can occur would be 4%. But these cuts go to Medicare providers, meaning the payments to doctors, to hospitals, to surgeons. They could automatically be cut up to 4%. And so this 4% has nothing to do with the reduction in your benefits, has nothing to do with anything other than some of the providers could be cut. Okay, but in the reality of this, I want to explain something to you. What normally happens is this. Congress can vote, and historically has voted, to stop the cuts. But if they don't, then this sequestration cuts are going to start in 2026. And so even though you may not have any coverage issues, the doctors and hospitals could provide, or could be provided, less money. Okay, so that's the fact. So let's talk this through and we'll close. Beneficiaries: no change to your benefits, no change to premiums, no change to your out-of-pocket expenses. So patients, you on Medicare, are not going to feel it directly. The providers could and may, anywhere from 2 to 4%. But here has been the history of this. And by the way, this all goes back to 2011 with some bills at that particular time. They started this. But Congress can respond. And routinely, now I don't know if they're going to in the future, but routinely they have waived or modified sequestration, okay, in the past. And it does require a 60 majority vote in the Senate for that to happen. But again, that's typically what has happened in the past. All right, so again, this is part of the consequence of it. We hope that doesn't happen to Medicare, and we hope that Congress would kind of override that and give the White House the authority not to have sequestration when it comes to the Medicare budget. All right, so listen, I hope you enjoyed this, hope it's helpful to you. It's a huge bill, like I said, 887 pages, a lot of details, and I hope this clears up some of the confusion that you may have around this bill.